represent the biggest hospital in Estonia, and I'm speaking here because we are going through a rather difficult exercise right now, which is about procuring for the new electronic health record. I wanted to say renewing, but then I realized that that is too much of demand towards the existing electronic health record. However, I also cannot say that we will renew completely everything, because this exercise is consisting of different parts, and obviously we started with the understanding the need for change. What is that we are aiming at, and why do we want to do it? I think Isabel said in the previous session very nicely that, first of all, the data is serving the treatment of a patient, and for that purpose the data is collected and the quality is sufficient. I don't think that it's actually always good, because that is always the question of quality, whatever this is collected for. But what I am in particular we are worried about is the use for secondary purposes, for the research, for the analysis, for the quality assessment, for the comparison, for sending the data abroad. That is where we really lack harmonization, agreement on how do we deal with this data. And that is all what we are keeping in mind. The treatment purposes, the reporting purposes for the health insurance, for the government, we are the state-owned hospital, and for the secondary use. We started the exercise with going through the analysis of describing what is that we have, what works well, what should we take over to the next electronic health record, and what is that we would like to change. So the exercise consisting of two parts, as is part and to be part. However, I have to say that as is part is in some ways easier than the part which is called to be, because we do not necessarily know the answer on the question, what do you want to have? Because sometimes we can describe the problem, but we as clinicians do not necessarily know what the solution is. So it is always better to describe the objectives in a way where we can describe what we want to achieve in terms of the research or the quality assessment or the treatment purposes. For example, we can express our interest of engaging patients more. I would say that, yeah, in sense of that they can also participate in this data creation and support with the patient-reported experience or patient-reported outcomes, or also patient-reported incidents, prim version. And that is certainly something that we can say. However, it is not always an option to ask clinicians to describe how it should look like or how the links should be made, because yes, the session is about interoperability, and I would say that it is all about this data exchange, access and sharing the standards. All that is also includes the information what we want to get from patients. Somehow we have to agree on this. Sometimes we already have these data sets agreed, sometimes we just have to add it. So what is that we have learned, good things that we already have in our electronic health record right now? It is set up as a modular electronic health record, which is good, because in one way we have a really old, outdated, from the previous century, the main core of the electronic health record, where we have a lot of written text. But Besides, we also have the modules, for example, the laboratory information system, pathology information system, radiology information system, which all work in their own small modules and which have the standards, have the agreed language, have the module which is accessible also from outside, which is analyzable, and that we can also use easily for the secondary use. We have a good cooperation with the Estonian Picture Bank, which stores all the images and which is also accessible for all healthcare providers who have joined the Picture Bank. But it also doesn't have only images, but also, for example, has the recording of the electrocardiograms. And also the existing connection with the Estonian wide health information system, which works. Yes, sometimes it has problems, but that is something that all electronic systems have. So I can't say that this is something that is terribly bad. Some points needs improvement, but nevertheless, that connection works, and we could learn from there. Then I think we could also learn and follow in detail what happens elsewhere in Estonia, because we have had, for example, the patient portal where patients have access to their health data existing already for, I think, 10 years now. We have a very good system of digital prescriptions. We have good work done in the Gene Foundation, but they are also going through the renewal. For example, the health information system is preparing for quite radical change. Now it is called the next generation health information system, which will bring in this genomic data, which will bring in the probably, hopefully, the PREM approach. And also we would very much like to engage with the patient portal so that we can share information better, and we can also get an input from patients, for example, also having an overview of the patient reported outcomes in case the treatment is happening somewhere else, not outside our hospital. So all these things we also would like to monitor closely in order to not jump right when everybody else is jumping left, or that we basically go the same direction and we share the tasks, because sometimes it could be that we do some part that the Estonian health information system can use or take over, or that they are developing something which we could use for our electronic health record in the hospital. And thirdly, most important, is the updates elsewhere in Europe. What is happening with the European health data space? What is that we have to take into account from that perspective? Because as a small country, I think both for the patient treatment, the unique patient treatment, or for the research purposes, the cooperation with the neighboring countries, other European countries, is very important. And that is what we have learned also from the European reference networks. Also, I think that European reference networks is a good example of the cooperation. But if there is some kind of development and we would like, for example, our pathology information be available, digitized, and ready to share with the members of the ERN, that is something that we have to take into account whenever the changes will take place there. So I think, having said all that, this is something what we are looking at, what we are considering in order to prepare for the change. However, I just cannot not mention that all this is very resource demanding. And not necessarily that we have already worked almost 2 years on this preparation work and established a number of working groups where people give their input and describe the needs and describe the situation and putting all this analysis together. But we did the first primary calculation about what it would cost us to take these all needs into account and get this electronic health record up to date. Not as it is right now for the purpose of reporting to insurance, but for the purpose of the treatment, secondary use, and reporting. And the first calculation was that for 10 years, including the maintenance cost, it would be 100 million, which is a little bit less than half of our annual budget of the hospital altogether. So I am just wondering, if we would like to bring this health data to the level that is possible and level that we need, how can we bring this resource question also to the level which is acceptable and that we can deal with? Because that is something that really bothers me quite a lot, because I don't see right now here a solution or an answer to my question.